Hello, everyone. Welcome to our presentation, Addiction Impact and Treatment, Families and Interprofessional Collaboration Through Personal and Professional Lenses. We're glad you're joining us. My name is Joe Bartholomew, and this is my co-presenter, fellow social worker, and friend, Katrina Norris. We're pleased to be a part of this conference this year, and we are really excited to present information that relates to addictions as it relates to both personal and in professional contexts. What I'd like to do now is to do a brief overview of the objectives in which we intend to accomplish today. So first, we want to recognize the impact of drug use and addiction, and then we're going to provide some cultural relevant formal and informal education to raise awareness and support the recovery process. Third, we want to identify the various components of medication-assisted treatment, or MAT, and how they combine and improve patient health outcomes. Finally, we're going to discuss interprofessional education and collaborative concepts, sometimes referred to as IPE. On that note, I'm going to hand off to my colleague, who will go over the sections that we're going to discuss today.
So to break down the presentation, we're going to briefly touch upon the disease of addiction and its complexity. And I will be sharing some of my own lived experience, which will bring us into thoughts and views, beliefs, emotions. It's always important when you are thinking about or talking about or treating addiction to address stigma, the illness, and how do we treat it. We will also touch upon the family unit and the teams that we work within in the social work profession today. So we will end by sharing some helpful tips and resources. And of course, in true social worker fashion, we will always talk about the advocacy component and how that relates to our code of ethics. We appreciate your time here today and hope that you will enjoy our presentation. I want to talk about the disease of addiction. And addiction is defined differently by the American Medical Association as well as the American Society of Addiction Medicine, or ASAM. And you can read those definitions. Both of them recognize that addiction is a brain disease. And I prefer the ASAM definition because it utilizes verbiage that I believe is more comprehensive and accurate, to be honest. And when we refer to as addiction as a treatable chronic disease, medical disease that involves complex interactions, and it includes the brain circuits and genetics, as well as the environment and the person's life experience, I think that that is the key components to understanding the disease of addiction. We all know that those suffering with substance use disorders, they behave and do things they're not proud of, and it becomes compulsive behaviors, and they're well aware of the consequences that come with that. So I appreciate the fact that the American Medical Association, as well as the American Society of Addiction Medicine, recognize the disease and the outcomes of that disease. But the most important component is it is treatable.
To provide you a little bit more detailed information in regards to the disease of addiction, we do know from the CDC that on average about 130 people die daily from opioid overdose. We also know that when it comes to substance use disorders, there are some startling statistics, and 20.5 million Americans 12 years of age and older that do have an SUD, and many times they do involve prescription pain relievers, and by extension, people had SUDs involving heroin at a startling number as well. We also know with prescription misuse, 4 out of 5 people who use prescription opioids and use them in a way that is considered misuse do go on to use heroin. And finally, there are staggering numbers when it comes to the healthcare cost, when it comes to prescription opioids, and ultimately the increased healthcare and substance use treatment costs that coincide with the prescription opioids and the overuse of opioids.
So it is complex. As Joe just described, there are staggering statistics There is patterns of unintended consequences. And so when we say the disease of addiction is complex, it is. But it's even more complex than what we talk about from the CDC or other notable resources, because the impact that it has to families causes severe dysfunction. And when I say severe dysfunction, I mean that in the truest form. I'm a pretty humorous person. I usually tie jokes into anything that I'm talking about. And I used to say, my family puts the fun in dysfunction. And I stopped saying that because once I was engaged in the complexity of addiction from the standpoint of a family member, what I realized was there was nothing fun about dysfunction. So how do we cope with the person we care about, our loved ones, how we cope with one another in our family unit becomes very dysfunctional. It becomes very unorthodox, and the emotional damage, it's inevitable. It's going to happen just because of the nature of the disease, the progression of the disease. And the statistics vary that anywhere from 20 to 23 million people are impacted by addiction. So when you think about that and put that into the connotation we're discussing here today, it's not just about the person suffering from substance use disorder. It's also about the families that are impacted, the parents, the spouses, the children, and it's dysfunction at its greatest.
Well, and I think that's the interesting thing and why this is such a pertinent topic for a social work conference is, as us both being social workers and many others who are social workers, we understand that substance use disorders, addiction, is well beyond just the actual disease of addiction and how it permeates through other parts of our lives. You'll hear me talk a little bit about interprofessional terms, so I wanted to just give you a brief overview. There are a lot of different terms related to interprofessional practice. So we have IPE, we have interprofessional collaborative practice, transdisciplinary practice, and multidisciplinary, and there even might be a couple more. But what I wanted to do is, in this context of this presentation, is that we'll be mainly talking about interprofessional education and collaborative practice and how disciplines, specifically medicine and social work, come together and work in a collaborative effort to address addiction and then ultimately treat addiction. There have been many studies about the teamwork, the tandem approach of medicine and social work, and this is one such study. The interesting thing about when it comes to medicine and social work, many times they're approached differently on how we work with the patients that we serve. So what is starting to increase is there's a more increased appreciation of what the other profession is bringing to the table. But there are certainly previous research studies that show that sometimes the medicine and social work combination hasn't always in the past meshed so well, but it is improving because we do know that we are getting data that shows that there are more benefits, definitely, and the growth of IPE and collaborative practice is growing because the experiential learning and the complementary services that we provide from each discipline is improving the services that we're providing to people. Some of you may have heard of SBIRT, Screening, Brief, Intervention, and Referral to Treatment, that is used many times within office-based or primary care settings. And that really takes a tandem approach when it comes to working with people with substance use disorders.
And Joe, I think there's a new appreciation, like you said, especially in the medical realm of things, where if the families need answers, they usually come to the social workers. The social workers know.
Exactly, and I use the term many times, and it's certainly not meant to be any sort of jab at the medicine profession, but I have often have this statement, do you want to speak to the physician in charge or the social worker who knows what's going on? Because
Absolutely.
as social workers, we really do get the whole big picture of what's happening, not just within that realm of being of a person being treated for addiction or a substance use disorder, but the whole big picture as it extends into our daily lives and the families and the people that are a part of our lives.
And we certainly are the experts in understanding the social determinants of health, and that has just started to come to the surface in a lot of those primary medical care centers and emergency departments, et cetera.
Mhm. And the interesting thing is, IPE studies do not limit just to medicine and social work. We're even gaining further information when we include nursing and all the other types of professions that combine to make a really comprehensive healthcare team.
So now I'm going to share with you the lived experience. And this is really a period of vulnerability for me, not only as a professional, but as a mother. And I believe vulnerability is healthy because we're talking about things that are uncomfortable as opposed to the taboo of we don't discuss that. And if you look at this from a historical context, for many, many decades, families hid mental illness. They hid substance use disorders. They covered up anything that could be viewed shameful. And so as we unfold the next few slides and we talk about the lived experience, it's not always easy, and that's okay. But the message needs to be conveyed so that we can help one another. After all, that's what we do. That's the beauty of our profession, is we help one another, even if it's a little uncomfortable. So I want to tell you about my daughter, Kaitlyn, and her story. Kaitlyn today is 25 years old, and she grew up in a middle-class home, was an honor student, an athlete, kind of the all-American girl, graduated midterm, had plans for a future, and all of a sudden life happens and she got pregnant, and I wasn't necessarily ecstatic about becoming a grandmother before I was 40. But nonetheless, life happens and we were going to get through it. And I was excited to become a grandmother. And at 19, she gave birth to her first child. And when she left the hospital after a cesarean birth, she left with 90, you heard that correctly, 90 Percocets. I didn't really think much about it. I trusted our physician. He'd been doing this for many years. He was a fantastic doctor. He worked in the hospital that I worked in. I'd served on medical committees with him. I trusted he knew what he was doing. I'd never had a cesarean birth. I didn't know the level of pain that was involved with it. And so we went about life with a newborn baby, and obviously things didn't turn out the way we wanted. My daughter's choice drug of choice is opioids, and that started with that Percocet. And I will also share that her ACEs score is a 5. So you always have to take into account a person's level of trauma, and ACEs is adverse childhood experiences. And we talk about these a lot in social work today, even though that study is more than 20 years old. And I didn't take into account always Kaitlyn's trauma history. Her father died when she was 2 in an automobile accident. So she did have some of those traumatic experiences that made her more susceptible. Now, ACEs is going to become very important as we go through the remainder of this presentation. And I'll save that till the end, so the element of surprise is there for you. But it really changed things because it got worse, and it got worse quick, more rapidly than you could ever imagine. So we went from prescription abuse to IV heroin use in less than 6 months. And that is the power of the disease of addiction. So in 2016, I obtained guardianship of my granddaughter. She was 18 months old. And that was for her wellness. That was to keep her safe. It was a voluntary guardianship, and it wasn't safe, the environment she was living in. So if you think that isn't bad enough, again, it gets worse. We had multiple overdoses. We had multiple arrests. My child became homeless. She engaged in dealing drugs. And when I say homeless, I don't want you to fall into that trap of under the bridge with the paper bag, stigma. A lot of homeless people are couch surfing. They're moving back and forth between friends, acquaintances, etc. And as a mother, when all of this is happening, I'm constantly juggling the internal tug of war. She's my child. I love her. I want her to be safe. I want her to get help. Yet I still have to protect this innocent child that I have guardianship of now. And the phone rings and your heart drops. And is it another arrest? Is it another overdose? What is it today? And at the same time, protect a child who can't understand the complexity of a brain disease like addiction.
I think first, thank you for sharing in this presentation, Katrina, about yourself and your personal family. But I think what really stands out to me is where you share there in that first bullet point, the time of 6 months between the prescription abuse and then the IV heroin use. And, in some ways that is such a short time frame, and it just goes to show how quickly it evolved from one type to another.
Absolutely. And when we talk about the use and the impact of opioids, it goes from getting high to getting well. And that's what most people don't understand. There is a change in the brain chemistry where people will do anything to feel well. And the only thing that will make them feel well is the opioid. And so when, 4, 5, 6, however many Percocets no longer work, but this direct IV use of heroin will immediately work in seconds to relieve those symptoms of withdrawal. So when you think it can't get any worse, it can. At that point in my career, I was opening one of the state's largest ASAM 4.0 addiction treatment facilities. And I was on my way to the ribbon cutting for the North Star Recovery Center that I was opening. And the local radio station on my way to work, local newscaster comes on with the news, and I hear on the radio on my way to this biggest day of my life, professionally in a sense, my daughter has been arrested. She's been arrested for dealing heroin. She's bonded out in under 6 hours. I don't know where she is. She's not answering her phone, yet I still have a job to do. I have people coming to this ribbon cutting, this grand opening of this new treatment facility in a county that had the highest drug overdose rate per capita in the state. So it was such a big deal. And when we talk about that family complexity and the family dysfunction, it was like, here we go again. This was supposed to be my day. This was the crown jewel of my accomplishments and what I had worked on for more than a year. And all of a sudden, the fire was taken from me because now my mind is shifted to, where's my child? Is she safe? How in the world did she get out of jail? Is she in danger? Because there's also a drug culture that invokes danger when people are arrested, that they will work with law enforcement, things like that. So this is all over the news. My phone's blowing up. I've got a job to do. And I will never forget that day when she was arrested, because I did what I had to do. I got on that podium, I cut the ribbon, I opened the treatment center, and when it was over, my CEO came to my office, and I was, of course, changing out of my attire and into normal business clothes. And when he came in, he said, "Man, you knocked that out of the park." And he's grinning from ear to ear. And I turned around and I was just sobbing. And he was like, "What's wrong? You did great." And I looked at him and I said, "They arrested my kid this morning. And I know the prison sentence that comes with that arrest." And so no matter what she had done, she was still my kid. And the thought of your kid being in prison is not the proud mama badge you want to wear. And then also not knowing, because she was out on bond, was she going to run? What was she going to do next? Would this lead to another overdose? The fear of prison make her suicidal, which is also very common in NIV heroin use. Sometimes intentional, sometimes unintentional. They know how to kill themselves, which is frightening. So that internal tug of war back and forth, I love her, but I'm so mad, was a roller coaster of emotions for me as a parent.
You know, and I can only imagine that your emotions that day were just all over the place, all these different emotions. And it just really connects to that subtitle of our presentation, through personal and professional lenses. Here you are, someone who is high ranking and at this point in your career where you're really proud of what is about to happen and what you're accomplishing. But on the other hand, this is happening in your personal life. And it just goes to show that when it comes to addictions, it can happen to anyone. It doesn't matter who you are, what positions you're in and such in your career, and someone who works in addictions, and it happens. Wanted to share a little bit of information about the field of medicine when it comes to addiction knowledge. I've been doing some research as part of some doctoral studies, and what I've learned is that physicians in medical schools and residency programs, the information and education that they get within those programs is somewhat limited. And what that extends to is, therefore, they have difficulties with identifying people with high risk opioid overdose. And they also aren't as prepared as they could be potentially when it comes to working with the people that they serve. And that, again, is based on the limited amount of addiction education they receive in medical schools and residency programs. And there's definitely room for improvement. Medical students and residents must be better prepared to identify, address, recognize, and be able to prescribe appropriately and refer when it comes to opioid addiction. Part of my research, I did a qualitative study, and this is some demographic information, a breakdown rather, of the population that I conducted the qualitative study with. And I worked with 14 internal medicine residents at a Midwestern University School of Medicine. And you can see the breakdown based on gender, the type of medical school, where the medical school was located. But I dove a little deeper, and I wanted to find out if they had ever had an addiction-related course in medical school. And you can see that more than half did not. And then I asked them, in that whole experience in medical school, if they were to give me an approximation of hours that they had learning and being educated on addiction. And the mean was 7.79 hours in that whole time. And of course, I wanted to know if they were going to be able to, or if they were interested in practicing beyond in an office-based or primary care setting. And it was a very low rate at that point, but that's not uncommon in residency programs because they're still kind of fleshing out what exactly it is that they want to do, because they could go into a lot of different areas. So that provides a brief breakdown as far as the demographics from that 14-person population.
Joe, that is amazing to me. I mean, 7 hours just doesn't even seem rational at that point, because we know how much addiction comes through family medicine unintentionally. I mean, people don't know what they don't know, and that includes physicians. So thank you for sharing that.
Well, My pleasure. And I think that it's interesting that it has always been, and again, this is where social work comes in, is many times it has not been uncommon in office-based or primary care settings that if there's an addiction-related issue, many times it's going to be punted to a psychiatrist if there is one within the system or in the clinic. And if not, then it's definitely going to be punted to the social worker. And that's why we take on working with that population, and we really take in, again, like I said before, that whole picture as to what's happening. And later in our presentation, that's why I'm a huge proponent of the two populations really working closer together to be able to provide this more whole person, comprehensive approach to addiction education or addiction treatment for the services or the addiction treatment for the people that we serve. So I appreciate you saying that. To give you a little bit more detail about what I did in this qualitative interview is you can see the breakdown. I had 5 different sections because I really wanted to know what they experienced as far as their addiction education in medical school, what their views were on different addiction-related topics, what they wanted to know. And then ultimately, I wanted to know at the end of the interview what they thought of social work and how we could come on board and assist them in learning more about addiction, learning more about addiction treatments and such. I think right now what we'll do is let's just take a quick 2 to 3 minute break for people to stretch, perhaps grab something to drink, and also to run to the restroom if they would like. So let's just do a quick 2 or 3 minutes. And if you have any questions, you can also ask those questions in the chat feature of the Zoom right now. So we'll take a quick break. Thank you.
Thank you. So we wanted to share with you some thoughts and views, beliefs, emotions that come along with this topic, and especially as we get into more of the personal lived experience. And also note that all of this is my experience, and it also has some research noted in it, but everyone is different and everyone experiences this different. And so we need to be cognizant of that when we are working with families, that everybody is at a different stage, including the person that we love or the person that we're helping. And we have to remember our ethics in that process too. And for me personally, those ethics were ingrained in my head, and it really did carry over into how I dealt with and coped with this situation as a parent, and a parent who happens to be a social worker and an addictions counselor. So the most common emotion that is talked about in families is enabling. And enabling is exactly what it sounds like. It is making excuses for your loved one. It's giving them money or ignoring their behaviors, blaming their addiction on other people, and even sometimes being dishonest and lying and covering up their mistakes. And I am not, I did enable. I enabled in a certain manner, knowing what I knew. I'm not exempt, is where I was going with this, is from I blamed other people for my child's addiction. I blamed the crowd she ran with. I blamed, places she was staying at, the environment she lived in. I didn't give her money. I was very adamant about the money issue because I had this deep-rooted fear that if I gave her $20 and she died, I I paid for her death. And so that was the one thing that I could never bring myself to do. And she would call me and she'd say, Mama, I'm hungry. And as a mother, when your child says they're hungry, there's nothing more heart-wrenching than my child is out there, she's in the streets, and she's hungry. But I can't give her money because there's no guarantee she's going to use that money for food. So I cannot tell you how many times I would say, "Where are you?" And she would tell me, and I'd say, "Okay, I have Domino's coming with a pizza." Because I could sleep at night knowing that I had paid for the pizza with my debit card over the phone and it was delivered to that house. I don't know if you can trade Domino's pizza for heroin. I'm sure it's a possibility, but as a mother, as just that core role of we make sure our children's basic needs are met. That's how I met that. And it is not uncommon for parents to enable out of their own guilt. We feel so guilty, like, what did I do wrong? And should I have taken her to church more? Should I have put her in extracurricular activities? What sign did I miss? I can remember saying, I knew I should have never let her hang out with that girl. I knew that girl was from a troubled family. And all of those parental guilt pieces that you run through your head, I think, is how enabling works. I feel guilty for everything I've ever done. Like any kid comes with a handbook. I mean, nobody has written the here's how to raise a good kid book yet. I mean, I wish they would, but I don't think it'd be effective because we all know how complex human beings are. But the reality is, enabling is a parental guilt emotion. And I found this clip on one of my support sites, and I do a lot of support sites, and we'll talk about that in resources. And it really was the turning point for me, and it really caught my attention. So I thought I would share it here with you. I'm not going to read it to you, but I'd like to give you a second to read it because it really hits home when you think about your child grows up to have a substance use disorder, and if love could have saved my child, we wouldn't be here today. But unfortunately, love does not cure the disease of addiction. And I knew that if I didn't stop enabling in any form or fashion, that I was part of the problem. I was contributing to her disease, and I just could not bear that as a mother. So there's emotions. There's lots and lots of emotions. There is the guilt. There is the enabling, but there's also hurt, and there's anger, and there's resentment, and it's the constant back and forth roller coaster of feelings. And you can see this picture of my beautiful grandson, and you say, why would you tie those emotions to this picture of this beautiful little boy? And the reason is I already had guardianship of my granddaughter. My daughter was actively using, actively homeless, actively dealing drugs, and lo and behold, the worst possible scenario that could happen outside of death is another baby. So she had already been arrested for dealing, and she came up pregnant. And my mother died in 2018, and my daughter told me that she was pregnant the day before we buried my mother. So I had the grief emotions, still coping emotions, and now you're going to throw this on me the day before I put my mother in the ground. I'm ashamed of the way I responded, but we're humans and we treat humans, and all of those things just came rushing in. And I was so adamant. I mean, I'm not doing this again. I'm not saving her again. I'm not taking this baby. She's going to have to learn. Obviously, she's going to have to pay her debt to society, and she's going to go to prison, and I'm not getting involved. And I was doing that to protect myself. I couldn't take any more. I couldn't take any more hurt. And then knowing addiction the way I know addiction, and how it manifests and grows, I knew there was no way for her to abruptly stop using. And don't forget, we've been through treatment centers, inpatient, outpatient, through this whole process. But when a person finds out they're pregnant, we have a really good opportunity to intervene for the sake of the child. A lot of female persons will attempt treatment again because they're pregnant. And unfortunately, that didn't work with my daughter. So then that whole resentment of how could you do this to a child? And it just is such a tug of war all the time that you're walking on eggshells, or you're compartmentalizing, which we all know in mental health is not healthy. You can't just keep pushing that down. It's eventually going to rupture. So it was definitely, and still is, an emotional roller coaster. You can't talk about this without talking about stigma. And I had always advocated, supported anti-stigma language in my entire career, but no more did it come to surface as to an experience I had in the NICU. And I was in the NICU with my grandson, and he spent a long while in the NICU. And I heard professionals, medical professionals, use terms like junkie, trick baby. And I don't know necessarily they were talking about my grandson, because there were several babies in the NICU that were experiencing the symptoms of neonatal abstinence syndrome. But just to hear that, and hear that from professionals, boy, that sting was real. And I'm still a mama bear. I'm still a human being. So I don't know if they were directing them towards my grandson or someone else, but it doesn't matter. Words hurt. And when families hear those words, the emotional response is unbelievable. It's not, there's not a good word to say how I felt at that moment. I mean, I was angry. I was very territorial, upset, and disappointed too, because these are professionals. How a professional talks like this doesn't make any sense to me.
Right. And I think that is where there's an ethical point for social workers to take on, is that we have to remember that words matter, and that we have to remember to use person first language
Certainly.
when we are working with our populations, and not just use it for ourselves with the people that we serve, but to let other professions know that regardless of what profession it is, words matter, and that instead of using certain terminology to describe people, or maybe their samples for screenings and such like that, that person first language is crucial in working with the population of people who experience addiction.
I want to talk a little bit about the illness and the treatments, specifically bring some attention to neonatal abstinence syndrome. That's important and near and dear to my heart. And when you look at the stats, 7 for every 1,000 babies are diagnosed in the United States, And you're like, 7 of 1,000 doesn't really seem that impactful. But when the CDC issued the statement that said every 19 minutes there's a newborn diagnosed in our country with NAS, that's what caught my attention, because it is staggering, heartbreaking. And if I chose not to show videos in this presentation because it is so traumatizing and it's triggering for me. Fortunately, my grandson did not experience the seizures that can occur in the withdrawal process, but he did experience several other symptoms of NAS. And it's a complex thing. I mean, imagine that, an addiction, NAS, they're both so complex. And they're complex because 75 to 90% of drug exposed babies can develop NAS, but the variation between who needs treatment and what treatment varies widely too. Most infants that experience NAS stay about 13 to 19 days in the hospital. Our experience was 13 days in the NICU, but this is an interesting part of my story. When my grandson was born, his UDS was negative, and I kept saying, there's no way. There's no possible way. My daughter went to jail on a Tuesday. He was born on Thursday because when she went into jail, she went into withdrawal, which hence made premature labor. And I was in my head, I was like, there's no way that her system could have been clean that quickly. But after he was 96 hours old, he began to show symptoms of withdrawal. And I share that because most infants are discharged from the hospital before 96 hours old. So I keep thinking about how many people have taken babies home and didn't know. Or, I mean, they may have known they used during the pregnancy, but they may not have known that that child was experiencing NAS, and they may not have received a formal diagnosis. But it's just so misunderstood and varies so much because, I mean, think about this. Obviously, when someone is pregnant and there's maternal exposure to substances, number one, we don't know what's in substances. That's why we've had the fentanyl deaths the way we have in this country. Everything is cut with multiple substances. And if you're mixing them, that can have a great impact as well. How much the mother is using, the time in development in utero, and the frequency, all of those things impact how NAS clinically manifest. So it is hard to put your finger on, do the good research on, because there's just huge variations. Some of those presentations are tremoring, irritability, high-pitched crying. And when I say high-pitched crying, that doesn't even do justice for what I experienced with my grandson. Remember when I said there was no way I was going to do this? No way I was going to get involved again. The first time I saw him at the NICU and I held him, I knew I couldn't leave him there. And because I'm a social worker and because I know how the system works, when they were telling me all the things that could happen, like this list, the sleep disturbances, the feeding difficult, all of those things, all I was thinking about is, I know people, I know resources. And I talked with the staff and they said, really, it's kind of like colic. Well, that was the understatement of the year, folks, because this child did not sleep through the night until he was 15 months old. I knew what I knew, but I didn't know what I knew, if that makes any sense at all. And he would scream so loudly, and you couldn't touch him, you couldn't hold him, you couldn't soothe him the way you soothe normal babies. You couldn't rub the nice lavender oil, the essential oils, because trust me, I tried everything, and calm him down. You couldn't bathe him, you couldn't diaper him. He was so hypersensitive to touch. And then God forbid you sneeze, because he would jump out of his skin. like the most abnormal startle reflex I've ever observed in an infant. And I don't know what I don't know at this point. And nobody really has a good handle on it, because in order to obtain long-term outcomes, and Joe, you know this as a researcher, you have to have the data. And it's extremely hard to gather reliable data with this patient population, this client consumer population, because they're in chronic stress, they're in family instability, they move a lot, and then the kids go to out-of-home placement so often that we lose track. But I think an important component in our collaboration here today is they totally mistrust the healthcare system, because that's who calls DCS on them. That's who acts like they're going to help and then doesn't, in the perception. So you really have a hard time tracking the families, the infants. But we have been able to get some studies that show different variations of long-term outcomes, such as behavioral problems, developmental problems, learning disabilities, and whatnot. We do know there's a high rate of abuse and neglect in babies that have NAS. And I tell you, it's not funny, but it's genuine honesty. I could never understand how a person could shake a baby. Today, I understand how a person could shake a baby, because there were times that I would have to strap him in his little mama-roo, you know, the thing is supposed to stimulate the womb and calm babies that are colicky. I would have to strap him in there and walk away and use my own coping skills, because it was unbearable. I can just remember laying in the floor crying with him, calling my husband home from work, having to file family medical leave for my husband, not to help with the baby, but to help with me and where I was at emotionally. So I really could understand now more as I experienced it. I'd studied it. I knew what I knew, but I didn't know what I didn't know. And that's what I tell everybody. But probably the most prominent one for me was infants that go through the NAS path generally are at a higher risk for SIDS. So this little dude don't sleep. And if he does sleep, let's say 4 hours, I'm jumping up and I'm in there in a panic thinking he's not breathing. So I went 15 months of sleep disturbance for myself and for him, all while I was still trying to hold my life together. And I still don't know what's going to happen. His physician says he's doing great. He's doing well on his growth chart. Uh, but we won't really fully understand until probably school age some of those long-term impacts to the brain wiring that occurred in utero.
Well, I think it just goes to show that you're trying to balance all these parts of your life, and it's a big challenge to try to do so. But I think it was interesting what you mentioned earlier about DCS, and there's a distrust many times that they can have towards the healthcare profession, and especially when you hear that term DCS, you know, automatically think about social work, because
Absolutely.
DCS employs a lot of social workers, and therefore, by extension, that's where social work, again, really, it's a ethical issue that we have to let people know that, you know, we hear that term that social workers, they take babies away and things like that. But we do so much more in educating and providing information, and why addiction knowledge within the social work realm is so important. And by extension, we need to provide that information and education to our healthcare professional peers.
Absolutely. And I know specifically in Indiana, DCS has really done a great job of educating their family case managers and having them work closer with multidisciplinary medical teams and saying, we want to help this family. We don't want to remove this child, probably because they can't find placements for one that has that kind of high-pitched screaming. That was a bad joke.
I want to give you a little brief information about MAT, medication-assisted treatment, when it comes to opioid use disorder. And we do know that there are 4 medications that are approved for the treatment of OUD, with naloxone being both oral and injectable. But we also know that often, many times, a crucial component of MAT is the second component. I call it kind of a two-pronged approach, is that behavioral therapies must be provided, counseling must be provided to people who receive medication-assisted treatment. And there is a little debate as to what behavioral therapies are, and they can come in different forms. So again, with medications, we know that there are 4 different medications, but again, with the naltrexone in different ways as far as injectable, oral, and then behavioral therapies can come in a lot of different mannerisms as well. Providing a little bit more information on MAT, we do know that Data 2000 and then recently CARA, it was actually in 2016, allows for physicians and nurse practitioners and physician assistants to prescribe buprenorphine in office-based or primary care settings. And again, the MAT model, there's a little controversy about that, because many times people believe that providing the buprenorphine is merely a substitution for one substance for another. And it is a highly regulated medication, and any prescriber that is interested in providing that service to people who have OUD, they must register with the DEA in order to be able to prescribe that, and they must go through advanced education and receive the waiver to do that, to be able, again, to provide that. But there's a lot of barriers to that. Again, a big barrier is the stigma. Even within the healthcare professions, many times people have these preconceived ideas as to what people who have OUD and other SUDs are like, and all these negative ideas of what people who seek services can be like, or maybe even divert the medication and use it. Other people could potentially be using it. So again, there's a lot of barriers about that. But again, that's where, again, I'm going to be going back to social work, as we need to know what these are, and then again, help with the promotion of educating our healthcare peers as to what these medications can do. And I think an important component of MAT is people have to realize you have to look at the term medication-assisted treatment. Mm-hmm. It's the medication that's assisting that allows for the treatment to happen. It's very difficult for someone who is withdrawing or someone who is craving to engage into treatment. So that's where the medication is an important factor in that. So I think a lot of people focus more on the medication instead of focusing on it's a comprehensive approach, two-pronged approach, if you will, on the engagement and treatment of OUD.
And for social workers, that's just part of the objectives of our treatment plan. And that's how I view it. And just to tag along on the MAT, we utilized Subutex at one point during the pregnancy of my daughter, and she had ups and downs. So there were times where she was on the MAT and times that she was off. But I do think that those periods of sobriety may have assisted in my grandson's development, because he was obviously growing at that time. And I wanted to share these photos with you because as children grow, there are times you can't get back. There are memorable moments that can never be recovered. So that person who is suffering with substance use disorder also suffers with that trauma and guilt, that they'll never see things like their child walk for the first time because they were incarcerated, because they were using. And a lot of us cannot empathize with that missing of memorable moments. And as social workers, we have a duty to show empathy and to be respectful of where people are. And so I wanted to share these as reminders that these are things my daughter will never get back. And I have to remember when she comes home that she's going to have some emotional tug of war like I've had as well.
moving on to this qualitative study that I did that I mentioned earlier in our presentation, I want to provide you some information as what I gathered as far as results. So when I was engaging the internal medicine residents, I wanted to know about their educational experiences on addiction. And you can see that many of them felt that in medical school that it was not addressed well and that it lacked. And they did receive it mainly through what you would expect in pharmacology coursework and when they were in their emergency department rotations. It was also interesting that many of them, when they are in residency, they have attendings that supervise them as a new physician. And many times they will take on that attitude that their attending has. So if their attending is very solidly in support of abstinence, the likelihood is they're going to follow that same type of idea when it comes to addiction. And then there were others who were very big proponents of MAT and other types of treatment. And of course, they followed that as well. And what I provided here are just a couple of different quotes that some of them mentioned. So I think these are always important because it really gives some idea of what they were sharing with me when it came to the interview. Another part was I wanted to know the educational experiences on addiction and get a little bit deeper in there. And they thought that these real world experiences were really crucial because when they were on their rotations or when they were in clinical settings, rather, they were getting a lot of great information. And that real world experience really gave them an eye opener as to what is happening in our nation when it comes to the opioid epidemic. And a lot of them did express that they wished that they had increased skill sets such as MI, motivational interviewing, and to better address and engage their patients that they work with. Another section is I wanted to know specifically what they thought of addiction because there's often a debate sometimes, even in healthcare, if addiction is a disease, is it not? Is it a moral failing? Is it a lack of will? Is it just a weak character? And they did believe that addiction is a disease, but they did report that it did increase actually. They did get a little bit strengthened. They do believe that sometimes external factors can factor into how a person develops an addiction, but they do believe that it is indeed a disease. And I think that what this is really important and says is that they want, again, more education and more training to learn more about this.
And Joe, that's great. I mean, I think what this shows is hope for the future from the upcoming physicians of the future, that perhaps they will have a different viewpoint and seek more education or even the waiver.
Yeah, absolutely. And this is what I think is exciting for us as a field of social work, because we do receive a substantial amount of education and we get a solid knowledge base on addictions. And this is where we, I believe, can come to the assistance of our peers in medicine by providing some of that to them, which I'll talk about here later in the presentation. Another part of the interview is I wanted to know what they thought about modalities when it comes to addiction treatment. And they didn't have a preferred way, but they thought that definitely more was better. And they also thought that the more tailored their approach to treating their patients or clients who have addiction-related issues, that the more individualized and tailored it was, the better it was, which is, again, I think, wonderful, because we talk about in social work that we really meet people where they are, and we really tailor and attempt to really work individually one-on-one, because everybody is so unique. Everybody has different needs. And we, again, this is wonderful because we can help medicine take on that more tailored approach when it comes to addiction treatment.
Absolutely.
I think also that's interesting is this also, again, ties back to that topic of interprofessional education. And again, that whole idea of working together as a team and providing that team-based approach. I wanted to know specifically what they thought of MAT when it came to OUD and the use of buprenorphine. And they had different variations as far as their exposure to it. And but they were mixed a little bit, and some of them didn't have a lot of information, and therefore they wanted more information about it. And I think that's encouraging because, again, if you remember, they were getting that mean average was 7.79 hours. Well, I'm sure that this was not covered. It is my guess that it wasn't covered heavily because they were just getting just the basics about addiction. So there's interest there in wanting to learn more about it and potentially receive the waiver, especially when it comes obviously to buprenorphine. But there's obviously other types of medications that can be used for the treatment of OUD. But they really want that potential to be able to help increase potential services for the patients that they serve. I think it's exciting, and we'll see how it continues with what we're gathering in research on this area. I am a social worker, and I wanted to know a little bit about what they thought of social work aiding them in this process. And I was very happy to hear that they had very high opinions of social workers and how they viewed them as far as the interprofessional team. And these are some of the quotes that I think that were quite impactful. I think the one that really stood out to me and made me feel good was this one on the at the very top, where it says, in terms of the way a team runs, social work has such a huge impact on that. I think a really good social worker is probably one of the things almost equal with a really good attending that makes the team run smoothly. So I think that really shows that they value social work and that they understand what we bring to the table. And that's crucial.
And I would just note that the comment that was made in the lower right, that's exactly correlated to the number of hours. They know we have a significant amount of training, especially those of us who take a mental health and addictions track in our master's programs, et cetera, that we know a great deal about the treatment modalities. We can make those recommendations. We can share resources, and really be a critical component at that table. So if you need a minute again to stretch, to pause, we want you to have a chance to process. We've given you a lot of information from a lot of different angles. So we would just wanted to give you a couple minutes to stand up and stretch, catch your breath before we get into the final stage of our presentation here today. Thank you.
And if you have any questions at this time, you can also share those in the chat feature.
Welcome back. We want to now move into some more discussion about the family unit as well as the teams that we all work in and partner in. So I'm going to tell you a little bit about the family unit. And if you remember way back in the beginning, I said you go through the roller coaster of emotions, the internal tug of war. And that was really speaking from my position as a mother, as a grandmother, but you can't exclude the other members of the family unit because they experience hardships as well, and specifically jealousy. And just think about this from a family unit's perspective. If you have one child that is suffering from substance use disorder and another that is not, guess who's getting all of your attention? And so for my family unit, I have two other children, and they're never going to say, oh yeah, we're jealous of Caitlin, or we're jealous of Caitlin's kids. They would never say that. But the reality is they're jealous because I also have 6 total grandchildren. And if you have 6 grandkids, but 2 of them live with you, and you get a break from the 2 that live with you, some respite care, and the other ones want to come over, you're like, oh no, I don't want to deal with kids right now. So it creates that jealousy of this child has taken the time, the energy, the money, and money just in itself, and the impact. We talked about statistically, what does substance use disorder cost, but what does it cost the families? Because I have spent thousands upon thousands of dollars over this 5-year period of time, and not just the standard inpatient addiction treatment cost, but many families who keep their children on their insurance till they're 26. You're still paying deductibles, you're still paying prescriptions, uh, the cost of childcare for raising children. I've spent easily $20,000 just in childcare over this period of time. And then in addition, you're spending money on treatment and prescriptions and whatever the next crisis may be. And all of those things are impacting the family unit, the family functioning. You can't exclude things like the marital impacts. And I'm very fortunate, but we know that substance use disorder destroys marriages. It destroys relationships of all sorts, whether it's the person who's suffering's relationship, whether it's the family involved. My husband's been extremely supportive. I feel very fortunate. I have a great support system. And what that did was make me step back and go, oh my heavens, how do people that don't have a great support system survive through this? I'm lucky enough that I have people in my life that care enough about me to say, let me take these children for a little while and give you a break. Or I have a husband who says, I'll work an opposite shift of you so that we can tag team this. And all of those sacrifices, I don't have those social determinants of housing or food insecurity. And so when you think about the families that we serve as social workers, they're struggling just with the bottom of Maslow's triangle. And I'm complaining about my hardships. And so you really go back in and think about, okay, I need to recognize how fortunate I am. I need to recognize how this can hurt my family and take every measure to protect my family, to make sure my other kids know they're important. Um, and to talk about it. Again, you can't just continuously compartmentalize because it'll come out in projection. And I just got a little therapist-y on you there, but I know those things, so I think about them, and then I want to help other families to know about it. But the thing that is hardest is recognizing that there's an emotional trauma here, a huge emotional trauma, that things like family therapy are going to be the only way to fix or to settle some of these unrested feelings and resentment that happens, and the fear of, we know that addiction is a relapsing disease, it's chronic. And so you're hypersensitive and you're always watching things and locking your medicine up, and just, really takes an impact, and it impacts the health of the family members as well. Because we all know, I mean, talk to any primary care doc, they're going to tell you that if you have high blood pressure, if you have heart disease, if you have any of these other issues, stress impacts them. Well, having a loved one who is suffering with addiction impacts your health. I can remember going into my doctor's office and saying, "Doc, I'm not well. I'm not well." And I know I'm not well. And to be a mental health professional and have to reach out for mental health help is unbelievably difficult. We promote it to other people, but when it becomes to us, it's hard to ask for help.
I've often said in jest many times that social workers, we are some of the best on the planet at dispensing advice, suggestions, but we're some of the not so great as taking it on. So, and I think it's interesting what you said about, when we see our physicians, and again, there's another opportunity for social workers to come into play because there's so much more going on. The physician is maybe treating you for what you're being seen for acutely, but there's a lot more underneath that's happening. And again, that provides another opportunity for the two professions to come together and collaborate interprofessionally. And by extension, we talk about the family unit, but there's a unit in our clinics and our healthcare systems and locations, is that this whole interprofessional activity that happens is, we as social workers really need to lead that, because we have a strong history in leading interprofessional teams. We facilitate teams. We take this interprofessional concept and we invite more people to what I call the interprofessional education and collaboration table. Yes. Everybody comes to the table, everybody shares. How are we going to work with the patients that we serve? Also, our social work organizations really need to propose or to push this more so. Even if they already are, it is something that is so integral to patient health outcomes and comprehensive treatment for patient care. Also, this ties into our ethics, because we are ethically bound that we must bring all these professions together and push for again, that whole approach, that whole person approach, that comprehensive approach of treating the people that we serve and providing the best services that we possibly can. So we are critical, and that's a huge component of what we must do as social workers.
And Joe, if I can just add on the ethics piece of this, that self-determination, when we have a group, our team together, and we all want what we want for the patient, we all know what's best for the patient. And I think as social workers, we have to be the person that also says, hey, what's the patient want? And what's the patient able to do? Because you can't make them do what you want them to do. We've got to be where they're at, and they've got to be at that table expressing what they're even capable of doing.
Right. So. And I love that you say that, because we provide a voice to them many times when they don't have that ability. And I think that's beautifully said. Thank you for saying that.
We'll go ahead and share some tips and resources for you as we are winding down our time. We hope that these will be helpful for you, and also that these slides and resources will be available through the NASW-Indiana virtual conference links. As a parent, as a family member, we have to educate ourselves. If you have a loved one suffering from substance use disorder, you have to know what to look for, because it can happen so quickly. And I always share and educate. There are some 3 simple key symptoms to look for in an opioid overdose. One is pinpointed pupils. The other is slowed or stopped breathing. And then the most obvious would be they're unconscious or they're non-responsive. So if families know to look for those things, then they also need to know how to respond. You can also recognize detoxing, which formally is the withdrawal. Your body is withdrawing from not having the substance. It looks very much like a severe case of the flu, but it has severe body aches, muscle cramping, and GI related symptoms, which means vomiting, etc. And I literally recall seeing ripples in the legs of my daughter. You could see her muscles rippling in her legs, and she was screaming in pain. And that's when it clicked for me that this was not just in her head. It wasn't that moral deficit. It wasn't that weakness or that lack of willpower, but her body was telling her, I have to have something. And that helps to understand. So how do you help? That's the $1,000,000 question, right? How do you help? They choose drugs over you. They choose drugs over their children. And that is not because they don't love their family. It's because their brain has been altered chemically, and it's been hijacked, and it's powerful, and it is long lasting. And a relapse is so common because of this. So I always say I love Reese's, like the eggs and the pumpkins for Halloween time, because they're better than the regular Reese cups. I don't know why, but they are. My brain is hardwired to know that if there's a dish of candy in front of me and it's got one of them Halloween pumpkins by Reese's, that's what I'm picking, because my brain knows that makes me feel good. It has more peanut butter in it. And I compare that to the same thing is true with those suffering with substance use disorder. Their brain has been so hijacked, when things get stressful, they know how to escape reality. So please, whatever you do, know your resources. Don't be ashamed to ask for help. And when you do those things, there's no shame in this. I wouldn't be here today if there was shame in it.
Some implications about IPE and IPCP is, again, tying back to what I was saying earlier, we need an increase of education in our medical schools and residency program curriculums, and this will help with lowering stigma. And it must be practical application and practical education for our medicine peers to know what it is to do when you work with people with substance use disorders and such, and the treatments that go with it. Also, if we don't emphasize this, there could be some thoughts that it may not be as pressing or as important that it really needs to be, and what it actually is with the opioid epidemic. And we also need to know that other specialties have more education on addiction, such as social work. So therefore, we need to be able to provide that information and that education to them, for them to be able to work with the patients that they serve. So the collaborative practice that we can offer and this education we can offer to our medicine peers can help with identification and ultimately treatment.
So I listed a few resources here for family members and for social workers in general. It is a good idea to know your treatment centers, both in inpatient and outpatient, in the areas that you live and or work. Know those MAT options that Joe's done such a great job describing today, along with other support groups. I am a proud proponent of peer recovery specialists, especially working in those medical teams, such as in the emergency departments when they bring in someone who has overdosed and they revive them with Narcan. Having someone there with that lived experience increases their likelihood of engaging in treatment at that moment. So they are critical parts of the team as well. And then also just to read, to read and educate yourself. I will tell you, shamefully, one of the best resources for me was a Facebook group, and it was called Parenting and Addiction, because it was convenient for me. I could jump on there at any time, day and night, when I was up, when Camden, my grandson, was not sleeping. I could scroll through there. I could read other people's stories. We prayed for one another. We shared stories with one another. And it was really nice to have that 24/7 support. I mean, I love Al-Anon, don't get me wrong. However, Al-Anon meets at certain times. Facebook's 24/7. So those are resources that are available for families. Social workers, obviously, we're advocates. That's what we do. I always say I'm the voice for the voiceless, but I can't be that if I don't take care of myself. So I'm sharing this lovely picture with you, and everybody goes, "Oh, he's so cute." And I really want to point out, look at my eyes in that picture and the dark circles, because I was not sleeping at that point in my life, and I was not taking care of myself. And stress can lead to many, many issues, physically and emotionally, like we've talked about. They're listed there. I've been through all of those myself. And if someone would have actually read my journals during this time, they would have diagnosed me or given the diagnostic impression that I was clinically depressed. I had every sign and symptom of what we know as major depressive disorder. And I was just flying on autopilot. And that's not healthy. My students will tell you, no one has told them more than me in their lifetime. You cannot pour from an empty cup. And so I had to take some time to refill my cup. And I encourage you to do the same. Remember when I said those ACEs were going to become important? They're very important, and I firmly believe that everyone should have their ACEs score on their shirt so we know how to engage with them. But since that's really not a trend yet, we're going to have to go with what we know, and that's just assume everyone carries an ACEs score of 7 so we treat them well and we're not traumatizing. My daughter is a 5. Her daughter is a 5. As of today, Camden is a 2. So if we can predict it, we can prevent it. And that's the beautiful thing about being aware of the ACEs scoring, what it does, and what it can do to prevent future traumas, harm, better outcomes. I don't want to be a statistic. I don't want my grandchildren to be a statistic. So I share that with you as a point of hope. And I will also share with you my mantra, if you will. Dead people can't recover. So we must advocate for those suffering with substance use disorder just as strongly as any other population that we serve. So keep advocating, keep working in your interdisciplinary teams. We need physicians to be able to identify, excuse me, we need physicians to be able to identify OUD during pregnancy. We need to standardize the care for mothers and NAS affected infants and really get that research that will help us make better informed decisions. And as family members, keep on keeping on. Find your balancing act, whether that's education, support, family therapy, but we can't recover dead people. We got to keep them alive in order to help them. And the foundation of our profession is built on advocacy.
As we are about to almost wrap up, first I want to say, Katrina, thank you for sharing your family story. I think it was powerful and it's going to definitely be impactful for many other people. And on that note, what I want to say on behalf of Katrina and myself is that we are social workers and we must lead these efforts. Do know as social workers that you are valued and you need to take that on. And I often say you must take your seat at the interprofessional table. Let the other professions know what we do. We do a lot. There are a lot of sometimes myths and misconceptions as to what we do and what we don't do. But we need to lead these efforts when it comes to addiction treatment, addiction education, and certainly through a collaborative paradigm. So please do that. And do know finally that, as you may already well know, that we are a change agent. That's what we do. We improve, we build upon, and we add to the context of what we're trying to do. So on that note, we will finish up and we will let you know that we have really appreciated you attending our session. And if you have other questions, please don't hesitate to email us. Katrina is with the state of Indiana, and I'm with the Indiana University School of Social Work. Again, one more time, it's been our pleasure to present for you, and we do hope that you've enjoyed it. And at this time, we'll wish you a great afternoon. And thank you so much again for attending.
Thank you so much.